All right, good day, everybody. We're going to talk about face and neck injuries. Going to go over a few things just so we can potentially have this class, but I'm not sure. It's a travel day plus some weather's coming in, so I just want to have it just in case everything's kind of crazy for me. Let's see here. All right, so we're going to talk about medicine applies the fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acute ill patient. We're aware that's the National EMS standard of competencies. So we're going to talk about trauma. We're going to disease in the eyes, ears, nose, and throat. We're going to try basically what we understand, how to manage it, how to treat it, and move forward. We're going to talk about trauma. We know trauma now applies the fundamental knowledge to provide basic emergency care and transport based on assessment and findings of acute ill patients. So what we see, what we find in our treatments, and what we're going to transport these patients to are going to be discussed. So we'll go over some of the recognition and management of face, neck, head, and spinal trauma. What are some possible life threats? We have spine trauma, pathophysiology, assessment, and management of penetrating neck injury trauma, and laryngeal tracheal injuries. So in spinal trauma, we're going to go deeper into spine trauma, facial trauma, skull fractures, foreign bodies in the eye, and dental trauma. So the face and neck are partially vulnerable to injury because of their relatively unprotected positions of the body. There's nothing there to try to guard it, to keep it from happening. It's a rather large, just kind of sits on the top of us and just kind of sticks out there. Some tissue injuries and fractures are common and vary in severity. Some injuries are life-threatening. Penetrating trauma to the neck is going to cause severe bleeding. I'm not even going to say maybe, it's going to. And an open injury may allow an air embolism to enter the circulatory system. So that's the reason why, as soon as we recognize that, we want to put a gloved hand over it so we can turn around and prevent that air embolism. So we know the head is divided into several different areas, but we're going to talk about the cranium. So it's also referred to just as the skull itself. It obviously contains our brain, and it's the most posterior portion of the cranium is called the occiput, which we'll show you that in a minute. On each side of the cranium, the lateral portions are called the temples and temporal regions. The forehead is called the frontal region. Anterior to the ear is the temporal region, and you can feel a pulse in the superficial temporal artery. So keep that in the back of your mind there. All right, so the 6 major bones, there's a knock on the table. 6 major bones of the face include the nasal bone, 2 zygomas, 2 maxillae, and the mandible. Bony orbit protects the eye from injury. It is composed of the lower edge of the frontal bone and the zygoma, the maximal, and the nasal bones. Only the proximal third of the nose is formed by the bone. All right, let's see here. All right, so the exposed portion of the ear is composed entirely of cartilage. It's covered by skin. So the external visible part is called the pinna. The tragus is a small, rounded, fleshy bulge immediately anterior of the ear canal. The superficial temporal artery can be palpated just anterior of the tragus. So we've heard people talk about, so here's your temporal joint, here's your occiput, your pinna is your ear. This is all cartilage is what they were talking about. So it kind of gives you some idea of some landmarks. About 1 inch posterior to the external opening of the ear is the mastoid process, and the mandible forms the jaw. So we want to make sure that we know these particular bones that we're referring to when we talk about the jaw, the mandible. So the neck contains many important structures supported by the cervical spine. The first 7 vertebrae in the spinal column, which is C1 through C7, The spinal cord exists from the foramen magnum and lies within the space canal formed by the vertebrae. The upper part of the esophagus and the trachea lie in the middle of the neck. The cricoid arteries are found on either side of the trachea, along with the jugular veins and several nerves. The larynx. This also contains the Adam's apple, which is located in the center anterior of the neck. The other portion of the larynx is the cricoid cartilage, a firm ridge of the cartilage below the thyroid cartilage. So if you see right in here, this is where your Adam's apple is. Then you have your cricoid membrane, your cricoid cartilage up in here. So this is the area that they're referring to. The cricoid membrane lies between the thyroid cartilage and the cricoid cartilage. The trachea. So this is below the larynx. This trachea does connect the oropharynx, and the larynx to the main passage of the lungs. On either side of the lower larynx and the upper trachea lies the thyroid gland. Sternocleidomastoid mastoid muscles originate from the mastoid process of the cranium and insert into the media border of each collarbone and the sternum at the base of each side of the neck. And this allows movement of the head. The eyes, the globe-shaped, approximately 1 inch in diameter. They are located within a bony socket in the neck called the orbit, composed of adjacent bones of the face and skull. In adults, the orbit projects over 80% of the eyeball. Between and below the orbits are the nasal bone and the sinuses. Here's the breakdown of the eye. I'll give you a little bit if you might want to screenshot that, take a little picture. It's good to know. So the eyeball of the globe keeps the shape as a result of pressure from the fluid contained within the two chambers of the eye. Clear jelly-like fluid near the back of the eye is called the vitreous humor. In front of the lens is a clear fluid called the aqueous humor. Here you go right here. The conjunctive matter is a membrane that covers the eye. The lacrimal gland, often called tear glands, produces fluid to keep the eye moist. The tear drain on the inner side of the eye through the lacrimal ducts into the nasal cavity. That's how we cry. That's how it washes our eye when we get something in there. The sclera is white, fibrous tissue that helps maintain the globular shape and protects more delicate inner structures. On the front of the eye, the sclera is replaced by a clear, transparent membrane called the cornea. Allows light to enter the eye. So this is the iris, is a circular muscle behind the cornea. So you see in this picture, you can kind of see what they're referring to. I think there's another picture coming up. The pupil is an opening in the center of the iris, and this allows light to move back to the eye. The anosclerosis is a condition in which a person born with different shaped pupils. The lens lies behind the iris, and the lens focused images on the retina at the back of the globe. The retina contains nerve endings, which respond to light by transmitting nerve impulses through the optic nerve to the brain. The retina is nourished by a layer of blood vessels between it and the back of the globe. Retinal detachment is when the retina detaches from the underlying cricoid and causes blindness. You can have these pretty easy from massive trauma. Retinal detachment, and they instantly go blind. Injuries about the face and neck can often lead to a partial or complete obstruction of the neck, the upper airway. Several factors may contribute to the obstruction. Blood clots in the upper airway from heavy facial bleeding, direct injuries to the nose and mouth, the larynx, and the trachea are often the source of significant bleeding and or respiratory compromise. Injuries may cause teeth or dentures to become dislodged in the throat. Swelling that accompanies direct and indirect injury to the soft tissues can also contribute to airway obstructions. The airway may be difficult when the patient's head is turned to the side. Possible injuries to the brain and cervical spine may interfere with the normal respirations. Soft tissue injuries. The face and neck are extremely vascular. Swelling in the areas may be even more severe. Skin and tissues in the area have a rich blood supply, so you're going to get, it's going to be very bloody. A blunt injury can cause a hematoma. The mandible injuries are common because of its prominence, a second only to the nasal fractures in frequency. So you get more nasal broken nose than you do broken jaws. Signs of a mandible fracture include misalignment of the teeth, the numbness of the chin, inability to open the mouth. So they'll tend to talk with their teeth clenched because it hurts too hard to open their mouth. So that may be a sign of what you, when they walk up to you, you're like, why are you talking like that? That's because it hurts for them or they're unable to open their jaw. Maximal fractures are usually found after blunt force high energy impacts. The signs of the maxillary fractures include facial swelling, instability of the facial bones, misalignment of the teeth, and fractured and avulsed teeth are common following facial trauma. Teeth fragments can become an airway obstruction and should be removed immediately. If you can see them, remember, don't stick your fingers down there, but try to remove them maybe with a suction device or maybe a forceps of that nature will help you remove those. So in our patient assessment, we are going to scene size up. We're going to make sure it's safe for us to go in there. Have our standard precautions, talk about eye protection, face mask, gown, gloves, anything that we need in that particular area for PPE, we're going to use it. And then we're, okay, how many people do we have? Is it safe enough to go in there? Are we going to be able to handle it on our own, or do we need to call for resources? So assess the scene. What does the MOI look like? Does it look like it is potential trauma, head, abdomen, neck injuries, all those? Anytime that you have a motor vehicle collision, sports injury, falls, penetration trauma, or blunt injury, you want to automatically assume that there's a face and neck injury. We have to prepare for the worst, and it's better to be treated that it's less than it is more severe. The primary assessment is focusing on identifying any life threats, which has been that way since the first day of class. We just want to make sure that the ABCs and life-threatening injuries addressed first. Any type of hemorrhage needs to be stopped. We need to bandage that. We need to 4x4 it, ABD it, trauma pad it, something. We need to try to stop that bleeding. So what do I want to do for the general impression? I want to look at the patient. Do they look severe? Is it something that's going to be obviously hidden if I go to apply a C-collar or anything like that? I want to control blood loss with direct pressure. Blood loss is our first and period thing that we need to apply. Now, if it's a face injury, a neck injury, we have to be careful about applying direct pressure, because if it's the neck, we could actually, cut off the pulse from the cricoid artery, and that we could cause them to black out. Are we going to be able to manually stabilize them? Do we need to put them in a C-collar? If you question it, you need to go ahead and do it. Check for the responsiveness using the AFPU scale. Remember, that's alert, verbal, painful, and unresponsiveness. Ensure that your airway is clear on your patient. Are they able to maintain their own airway? If they're not, you need to do your best to secure that ASAP. If the patient is unresponsive or has significant altered level of consciousness, consider a properly sized oropharyngeal airway. We need to make sure that we do the airway assessment very fast. We're going to palpate the chest for a DCAP BTLS. We are going to splint, or otherwise restricting chest wall movement is contraindicating. We don't want them to move around. We want to be able to try to secure that, recognize that things are going on, so we need to fix it in place the best we can. I'm assessing the pulse and the quality. Significant bleeding is an immediate life threat. let's fix it. Let's make sure that it's taken care of and that it's done. Let's make sure things are our circulation continues to keep blood going round and round instead of outside the body. We need to transport this. We need to make a transport decision pretty quick. Is this one of those patients that we can stay and play, potentially wait on another unit, or is this something that I can sit here and manage before we go to the hospital? If I need backup, let's go ahead and get ALS backup en route. Let's not wait on that. And a patient with an internal bleed must be transported quick to a physician, to an ED, or somewhere that they can use scans, some scopes, anything like that to potentially look and stop that bleed. That is a severe issue, and we need to try to stop it as fast as we can. The patient who has significant MOI, but whose condition appears stable should be transported promptly. They may be going through signs of shock. Even if the patient has no signs of hypoperfusion or other life-threatening injuries, there is a possibility of eye injuries. And we can still have lingering effects along these patients. So we need to make sure that the ones that say, no, I'm okay, I don't need to go, try to include those to be transported also so that they can be just checked out. So on our history, we want to obtain medical histories. We want to look for the signs and symptoms of past medical history. Do they have any bracelets? Do they have any anklets? Anything like that that can tell us potentially what kind of medical history they have. Do your best to obtain a sample history. If you can get it from the patient, fine and dandy. If you have to get it from bystanders that only can tell you what they know, get as much information as you can. You're not going to get any information from an unresponsive patient, so you're going to have to go off their signs and symptoms. If multiple systems are likely to have been affected, start with assessment of the entire body with DCAP BTLS. I want to reiterate that first bullet because that is super important. You need to make sure anytime that you're assessing an area that you DCAP BTLS that particular region. So if I'm working on the right arm, I need to DCAP BTLS the entire arm to make sure everything is okay. Ensure that you control the bleeding and maintain note the location of injury because you're going to have to come back and reassess that later. During the physical exam, use both your hands and your eyes. Let's see. If your patient is responsive, and you should explain exactly what you're doing and what you're looking for. Don't just assume that they understand. Make sure that you tell them, hey, look, I'm fixing to start touching you on your right arm. I'm trying to make sure that there's not any other injuries that I can't see. I just want to, so let me know if you can feel it and if you are in any pain. In our physical exam, we want to make sure when you evaluate the eyes, you start with the outer aspects and work towards the pupil. Because if you start with the middle and work out, you're going to dilate the eyes already from the light, and then it's not going to be as responsiveness. The visual acuity is considered within vital signs of the eyes. Assess vital signs to obtain a baseline, which I pray that you guys have already done that and that you understand, you know what to do. With facial and throat injuries, baseline information and respirations and pulse is very important. Always use a monitoring device, as in AED with vitals. Let's say you have a LifePak 12 or 15 or Zoll, anything like that, that they can use those. Plus with the pulse ox, those are awesome. They can help you maintain that assessment. We're going to repeat our primary assessment as we continue down the road. If we need to go, we can, once we've done our primary assessment, we're going to start back over reassessing this patient to make sure that nothing has changed, or if anything has changed due to treatment, we need to make sure that we note that. Recheck the patient's any type of intervention that you've done. If it is particularly important in the patients with facial neck injuries because the ease in which injuries can affect associated symptoms. The patient's condition should be reassessed every 5 minutes. And you want to provide a complete spinal mobilization and patient with on a patient with suspected spinal injuries. All right, sorry about that. So we're going to continue to reassess our vitals, recheck the patient interventions. What we've done, we need to know, we need to move past that. This should be done at least every 5 minutes. Provide a complete spinal immobilization to any patient that you suspected. If you potentially suspect spinal immobilization, you need to take those procedures, precautions, and take care of them and make sure that they have spinal precautions taken. Maybe. Next. All right. Maintain an open airway. Be prepared to suction the patient. Consider dropping an OPA in. What that'll do is help us secure our airway. Control significant signs of bleeding. I hope you did that in the first case, that you recognize that that's there. You want to stop it to begin with. Always provide high flow O2. It does help the patient. If the patient has signs of hyperfusion, treat the patient aggressively and for shock and provide rapid transport, because we know that that's coming. We know that's an outcome of potentially what we don't want to see. Do not delay any type of transport or decision, and the patient needs to go. Do not delay any transport of a severely injured patient just to complete a non-invasive treatment. We don't need to worry about that. If we think they need to go and they show in that they need to go, let's transport them. But in our documentation, we need to include a description of what the MOI was, how we found the patient, what, if they're from an NVC, try to take pictures, try to add a very good description. Those things help us out in the long runs. Treat soft tissue injuries to the face and neck. Is this going to be the same as treating everywhere else in the body? We are obviously going to try to look for our life threats, our XABCs. We're going to follow standard precautions. We're going to put gloves on. We're going to put masks. We're going to what we need to do. We're going to cover our eyes. Avoid moving the neck in the patient with a suspected cervical spinal injury. Need to make sure that those are safe and those are locked down. We are going to control the bleeding. We're going to apply direct pressure, which we know that. We're going to use a tourniquet at the last resort. If we have to, we can apply direct pressure. We can apply 4x4s. We can use roller galls. But so it says on the last one, do not apply excessive pressure if there is a possibility of an underlying skull fracture. Never, always apply light pressure there. We don't want to try to just push it all the way through because we may be affecting something else that we can't see. When an injury exposes the brain, eye, or other structures, cover the exposed parts with a moist, sterile dressing. That is a very important statement. If there's injury that exposes the brain, the eye, or other structures, cover it with a moist, sterile dressing. We do want to apply ice, but we do not want to apply it directly to the skin. You need to put something, wrap the ice, put it around something. For any soft tissue injuries to the mouth, cheek, and nose, expect a lot of bleeding. There may not be any in the cheek area, but if it's to the face or anywhere else, you may have a lot of bleeding around. Physicians can sometimes graft pieces of skin. We'll see those wonderful physicians that can do these surgeries, and you might not even notice anything. But if you find portions of a vole skin, wrap them in a sterile dressing, place them in a plastic bag, and keep them cool. So they potentially can use that, but it needs to be packaged a certain way. Really importantly, on your screen, the last one is label and deliver to the ED. Label the patient's name on what you found. There has been instances where that's the reason why when you go have surgery, they make you draw a circle or an X on that particular body part and initial it. That is because that's happened before to where people have things that are cut on the wrong side because there was some miscommunication going on. If the skin is still attached in a loose flap, place the flap in the position that is as close to as normal as possible. We want to try to keep that moist and covered with a sterile dressing at the same time. I know it says dry, but you got to think when the skin starts drying out, what does it do? It wrinkles. So you have to take precautions into that. We don't want it to lose any shape of the form of that is potentially in. And eye injuries are common. They are particularly common in sports injuries. They can produce a lifelong complication, as in blindness. So our proper treatment in the field will minimize this. It may help with minimizing of pain, but it also potentially can prevent permanent loss of vision. After an injury, pupil reaction or shape and eye movement are often disturbed. Abnormal pupil reactions sometimes are signs of a brain injury, which you may see as a TBI, rather than just an eye injury. So don't focus in on that particular injury. Keep your eyes open, no pun intended, to make sure that you see the entire picture. Treat signs with a thorough examination. Always examine them. Look for specific anomalies or conditions that may suggest the nature of illness. So that can tell us what's potentially happening. If we see blood all over the ground, is there anything around that may have caused that? If we can't, there may actually be where that particular weapon may be still stuck in the particular person. Or if you go on scene and you find the treatment of an eye injury, and it may be a pencil, we can stabilize that. There's things that we can do to help stabilize those. For foreign objects, you can see, you're gonna be able to see large objects. Sometimes the small objects are not gonna be able to be seen, but we get a lot of eye injuries out here in the oil field. We have a lot more injuries to the eye and hands than anywhere else. So we have to be extra knowledgeable about how to treat eye injuries, because we have to flush them out. We have to make sure that there's particular ways that we can treat those and it still be considered a first aid. Now, granted, yes, in the field, we're going to turn around and transport all of our patients to the hospital with these potential injuries. But you have to remember, I am the hospital out here, so I have to be able to do this. Anytime that you irrigate the eyes, make sure it's with a sterile saline solution. Sometimes you can use saline water that's on your truck, or you can use a IV bag solution if you happen to have extras. A nasal cannula that can be turned upside down and help flush the eyes. You can see they're pulling the eyes open, and they're also with the hand, both hands are pulling out, but they're also holding the nasal cannula in position. Now you have to make sure that you have somebody else that can be there to help you, because at this point too, you have to be taking solution. You're going to be sucking it out of into a 60 cc syringe, and you're going to be trying to squirt it down the tube with the 60 cc syringe. So you can't do it all yourself. You need some assistance. Foreign body will leave a small abrasion on the conjunctiva. General irritation usually will not wash out foreign bodies that are stuck to the cornea or lying under the upper eyelid. If you spot a foreign object in the surface of the eyelid, you may be able to treat or remove it with a moist, sterile cotton tip applicator. That is what we do out here. We have to flip the eyelids, and then we are able to assess them in a better position. We can clear the eyelids with some fluids, we can wash it out, and we can use some sterile applicators and potentially remove the foreign debris. Foreign bodies may be impaled in the eye, must be removed by a physician. You need to go see an ENT. They do have some eye physicians that work in the ER, but they need to go see a specialist. Your care involves stabilization of the object and preparing the patient for transport. When you see a subject with an impaled object in the eye, bandage both eyes with a soft, bulky dressing to prevent any injuries. Because if you think, why have I got to do both? Well, your eyes work in tandem. If you turn your eyes to the left, both eyes look left. So let's say you have a potential pencil in the eye. You need to stabilize that. And the best thing that we can do to stabilize that is some of the foam cups that are out there. You can use a small styrofoam cup, poke a hole in the end of it, slide it over that particular pen, pencil, something like that. And then you stabilize it, and then you have to wrap both eyes. Now, again, when you do that to somebody, remember what you're doing. You're taking away their sensory. So at that point is you need to be very descriptive about what you're doing. You're taking away one of their senses, and they become, a lot of people have a lot of anxiety when it comes down to that, just because they can't see what's going on. Burns to the eyes. So here, the best thing you can do is flush the eyes with the water or sterile saline solution. Flush them constantly for at least 10 minutes. Direct the greatest amount of irritation solution to the eye with the eyes as gentle as possible. I'm not trying to, flush it with force. I'm just trying to continuously flush their eye. You can see here they're using a nasal cannula on figure A. B is just a emergency station that's got an eye wash station, which that should be turned upside down so they can look down upon it. They don't have to look up. Then you have a bottle flush, and then you have a basin to where you're trying to flush it from the side where you can dump their face down in there. I'm not saying D is the most suffice, but I have seen it done in the past. We don't practice that much anymore. On chemical burns, you may have to force the eyelids open because they're going to be held tight as fast as they can. Think about the easiest chemical burn that we can talk about is pepper spray. You have to force the eyes open to wash that out. You need to wash that as much as you can. Wash the corner of the eyes, wash the top eyelids. You're going to have to continuously flush it for at least 20 minutes. That's the easiest thing that you can do. Thermal burns are due to a fire. Eyelids are frequently burned and require specialized care. Cover both eyes with a sterile moistened dressing and rapidly transport them to the facility. Light burns, we talk about infrareds, laser beams. They all can cause significant damage to the sensories of the cells of the eye, but it's not gonna, on short term, it won't cause loss of sight. You have retinal injuries caused by exposure to extreme bright lights. Are generally not painful, but are not painful, but they may result into permanent damage. Think about like a welding, the arcs that the weldings give, that sometimes those can do that. Superficial burns of the eye can result from ultraviolet rays from there we talk about that, from ultraviolet rays from a welding unit, light from prolonged exposure to a sun lamp, or reflected light from a bright snow-covered area. It may not be painful at first, but it may become 3 to 5 hours later. Severe conjunctivitis usually develops with redness, swelling, and excessive tear production. Cover each eye with a sterile moist pad and an eye shield. If you have any type of lacerations, make sure you cover the injured eye with a protective metal eye shield, cup, or sterile dressing to prevent them from drying out. You want to apply a soft dressing to both eyes. It needs to be moist. Make sure that they're all covered. If there's a laceration to the globe itself, apply no pressure to the eye. Just keep it covered. Not attempt to reposition the eye. Cover the eye and stabilize it with a moist, sterile dressing. Have the patient lie supine to prevent loss of fluid from the eye, and cover both eyes to prevent further injury because of the sympathetic movement. All right, so any type of blunt trauma, we're gonna have a hypemia, and hypemia is bleeding into the interior chamber of the eye. Orbit fractures, which is gonna blow out fracture, and that is a bone fragment can entrap some of the muscles that can control the eye movement, causing a double vision. Protect the eye with a metal shield and cover the other eye to minimize movements. And then you can also talk again about the retinal detachment. Eye injuries, signs and symptoms. So you may talk about, okay, well, those are all on your screen. I'll read those. Some of the management that we can do is we can keep the eyelids closed. Again, cover the lids with moist gauze and hold the eyes, hold them close with clear tape. If you need to do that, you can. A lot of times the patients are able to keep their eyes closed and it feels better with them closed versus them open. So you may not have to take them closed, but remember that can be a potential option. So on blast injuries, we're going to have signs and symptoms of blast injuries range from severe pain, loss of vision, and foreign bodies within the globe. The biggest thing you can do is it depends on the severity of the injury of some of the management that you can do. You can treat those like the rest of what we talked about. If it's potential debris, you may be able to flush it out. You may be able to work it out some form of fashion. But other than that, you're going to have to treat depending upon the severity of the injury. Sometimes people get contacts lost in their eyes. And generally, we do not attempt to remove the contacts under a chemical burn. That is not what we need to do. To remove a hard contact lens, it's usually a small suction cup. I've never used one of these. I don't even have these out here. It's just something that we try to keep them to keep their eyes closed, and we'll take them to the facility, medical facility, so they can have it removed. There's just some ways right there about how to remove contacts. So injuries to the nose. So nosebleeds are epistaxis. Those are very common. One of the most common causes is digital trauma that is categorized into anterior and posterior epistaxis. Anterior nosebleeds usually originate from the area of the septum and bleed fairly slow. Posterior nosebleeds are usually more severe and often cause blood to drain into the patient's throat. Blunt injuries to the nose may be associated with facial fractures, some soft tissue injuries, head injuries, and/or injuries to the cervical spine. Here's a little picture of how you assess the structures of the nose. You're going to be able to just grab, you want to be able to assess the bone right here. This is the bone that we're looking at. Potentially be careful in here. If there's any swelling or anything in here, that's going to indicate that there is a fracture right in there. Patients with severe nasal injuries may have cervical spine injuries. You may see CSF, may escape down through the nose following a fracture to the base of the skull. We are going to try to control the bleeding, apply direct sterile dressing. If the patient is bleeding heavily enough, it could be the signs of a significant trauma. For a non-traumatic patient who is bleeding from the nose, place the patient in a sitting position, leaning forward and pinching the nostrils together. So the ears are divided into three parts. You have your external ear, your middle ear, and your inner ear. You can see how it's divided here, what is also located within the outer ear, middle ear, and inner ear. All right, so ears are often injured, but they may not bleed a whole lot. And local pressure if local pressure does not control the bleeding, apply a roller dressing, kind of squeeze it to the head, maybe try to, it'll help clot it. In case of an ear avulsion, we need you to wrap the avulsed part into a moist, sterile dressing with a plastic bag labeled with the patient's name on it. Tympanic membrane rupture is a sudden change in the pressure created by a blast wave that may cause rupture. Patients will report severe pain, difficulty hearing, and ringing in the affected ear. So here, injuries may be caused by inserting objects too far into the ear. Children place foreign bodies into the external auditory canal. All foreign bodies should be removed by a physician. Do not try to manipulate the foreign body. You may push it further into the ear. Clear fluid coming out may indicate a skull fracture, so be open-minded about that. Look for the MOIs. Let the mechanism of injury tell you what you potentially might see. All right, so facial fractures do usually result from a blunt trauma. It's not something that's mainly common on just a regular going around, like baseball injuries, sports injuries, but it is due to a blunt force trauma. Assume that any patient who has sustained a direct blow to the mouth or nose has a facial fracture until proven otherwise. Signs and symptoms include bleeding in the mouth, inability to swallow or talk, absent or loose teeth, and having movable bone fragments of their face. So facial fractures, let's try that again. Facial fractures alone are not acute emergency injuries unless it has serious bleeding. In addition to external hemorrhage, there is the danger of blood clots lodging in the upper airway and causing that to be an obstruction. Plastic surgeons can repair the damage to the face and mouth if the injuries are treated within 7 to 10 days. Remove and save loose teeth or bone fragments from the mouth because it is sometimes possible to have them replanted. Remove any loose dentures or dental bridges to protect against the airway obstruction. And another source of airway obstruction is swelling, which it can be extreme within the first 24 hours after the injury. So dental injuries can be traumatic to patients because it's a visual thing, like they see they're holding their teeth in their hands. The injury bleeding can occur whenever a loose tooth is violently displaced from its socket, like when it's broken or the root's been yanked out. Apply direct pressure to stop the bleeding, perform suction if needed if there's a lot of blood there. Incorrect or loosened teeth are possible airway obstructions. So what are we going to do to save this? So we're going to handle it by the crown rather than the root. We don't want to touch the root. Place the tooth in a tooth storage solution, cold milk or sterile saline. It is recommended that they have it replaced within 20 minutes or to 1 hour after the trauma. 1 hour is kind of the max line. They may try, but if there's other issues going on, they're not really going to try to replant that. Have injuries to the neck, maybe an impaled object. So if you're unable to control the bleeding, consider it. Just lost my train of thought, y'all. So if you're unable to control the bleeding and it does compromise the airway, that is the only time that we can remove an object if it's a compromising of the airway. Provide direct pressure both on the inside and outside of the cheek, and the amount of bandage should not be so overwhelming that it occludes the mouth and makes it difficult to swallow. The neck contains many structures vulnerable to injury by blunt trauma, including you have the upper airway can be affected, the esophagus, your cricoid arteries, and your jugular vein, your Adam's apple, your thyroid cartilage, your cricoid cartilage, and the upper part of the trachea. Blunt injuries, any crushing injury of the upper part of the neck is likely to involve the larynx or trachea. So some fractures of the upper airways and laryngeal cartilage. So signs and symptoms include loss of the voice, difficulty swallowing, severe and sometimes fatal airway obstructions. And leakage of air into the soft tissues of the neck can cause a subcutaneous emphysema. How are we going to manage this? We're going to always call ALS support at this time because we know if the patient turns to go south, we need a secure airway, and that's an ALS can do that. Consider spinal mobilization restrictions. We may just apply them into a C-collar. If they're not complaining of any back pain or anything, like that, it's okay to just board them and not put them on a spinal board. But again, let me say this. You need to do exactly what your med control and your protocols of your local agency say. If anything's penetrating, it can cause profuse bleeding. Remember, of all the vessels that are in the neck, think about how venous the face is. Injuries to the cricoid and jugular veins and the neck can cause the body to bleed out. We know that. The airway, the esophagus, and the spinal cord can be damaged by penetrating injuries. Direct pressure over the bleeding site will control most neck bleedings, and assess for signs of shock to initiate spinal motion restriction if indicated, and always apply high flow O2. If there's any type of laryngeal injuries, unrestrained driver strikes the steering wheel, that's a really big one. Snowmobile rider or off-road bike strikes a clothesline or a fixed wire, that can get them. The larynx becomes crushed against the cervical spine, resulting in soft tissue injury, fractures, and/or separation of the fascia. These strangulation injuries can also be found in either intentional or unintentional hangings. Anytime there is a suspected injury to the larynx, suspect possible cervical spine injuries. Penetrating or impaled objects to the larynx should not be removed unless they interfere with CPR. Let me say this again. Penetrating or impaled objects in the larynx should not be removed unless they interfere with CPR. Stabilize every single impaled object that you come across with. As long as they're not obstructing the airway, secure them. Make sure that they don't move. And when you do move, you need to reassess that, make sure it stayed in place. Significant injuries to the larynx pose an immediate risk of airway compromise. So there you see we have respiratory distress, hoarseness, pain, difficulty swallowing, cyanosis, pale skin, sputum in the neck, subcutaneous emphysema, bruising on the neck, hematoma, and bleeding. Signs and symptoms of a larynx injuries include respiratory distress, hoarseness. I just said all that. Some of the things that we can do is we can manage and provide O2 and provide ventilation support if need to. And a C-collar, man. C-collar is really important. A lot of people don't think about applying C-collars and just a little thing. I like to use C-collars every time I intubate somebody. When I drop a tube down somebody's throat, I want to make sure that I have them C-collared. And the reason why is because it helps secure and maintain my airway. It doesn't allow for the neck to fold down or lean over to the side. And if it does, I also have a way that I can secure my tube to the C-collar. So that point being proven, I want to make sure that I put them in a C-collar so it can help me help the patient. It's not going to cause any harm. And then once I move them, it's more rigid for them, and I can reassess them. If I look, the tube's marked at like 22, 23 on their teeth, then I know, hey, look, it didn't move. Most of the time when somebody's head is not restrained like that after intubation, they move a lot, and you'll notice your tube placement will move. Ladies and gents, this is the end of the class. Please see your class code 17-496 exclamation. That will set you up for your exam. Your test for tonight. Take your test and good luck on that. If anybody has any questions, concerns, please send me a message on Discord and I will help you the best that I can. Thank you, and y'all have a great evening.